Okay. Yeah, I think we'll move on to your talk, Dr. Anand. So Dr. Anand would be doing what Dr. Rajesh had not covered, post-refractive surgery, keratectasia, which is something that we all dread, and how to go about it.
Thank you, Sapna, for inviting me to be a part of this. There's no financial interest, but it would be nice to have some. I'll start with one patient of mine, government employee, underwent surgery, cataract surgery in 2001, referred to the cornea clinic as the last resort because the vision was not good post-surgery. And when we did put the patient on the scan, and that was the time we had the op scan, this is the right eye and this is the left eye. And when we actually delved into the history, we realized that the patient had undergone LASIK by one of the renowned surgeons about 15 years before the cataract surgery. And this was actually post-LASIK ectasia, which was undetected during a normal scans. Patient disappeared, then came back to us 5 years later, and you can make out that the ectasia has actually gone up. The cornea is a lot more irregular, and across the pupil you have almost about 13 diopters of irregularity. So the quality of the vision, even with an IOL inside, is actually very, very poor. So what we did for this patient was to basically do a topography guided treatment. Just for explanation, what we did was the area that was flat on the topography was steepened, and the area that was steep was flattened. So this area of the laser where is directly on the steeper part of the cornea, which is the ectatic part. And with this is the post-op scan. So if you do the planning right, the aberrations come down. We put this patient on a eye trace. This is pre-surgery and this is post-surgery. So the clarity also tends to get better. If you look at the pre-post scans, this is pre of the right eye, and you can make out it's now oblique astigmatism can be corrected with a pair of glasses. Same way in the left, slightly less irregular cornea than what we started with. So if you do the planning for the topography with a stepwise approach, these patients actually do well. So when you imagine keratectasia, the picture on the left and the right requires similar management. You got to stop the progression, you got to stabilize the bulge, you got to improve the contour through intervention, and you need to have measurable results. Just for the information, that is not me. So there are some points for discussion. One is what is the incidence? Second is there any way to predict it? Any etiology, prevention, what is the literature on that? And the broad three procedures which are most common, is there any difference, and if there a nomogram for the management. I did check the basic sciences because I have an interest. There is a difference in the enzymes in the tear film. So in alpha, especially at the level of the epithelium, so in the alpha protease inhibitors, which are almost normal in keratoconus, the others tend to have lower levels. The second is, of course, matrix metalloproteinases. These actually melt the cornea. So in dry eye patients, they tend to be also higher, and similarly in keratoconus. So the pathology in keratectasia and healthy versus keratoconus is slightly different. So this is something you need to remember. So the principles of keratoconus management broadly apply, but not perfectly. Now, what is the incidence across to my understanding is about 0.03 to 0.6% based on my literature review. And remember that we have gone up from 250, then we evolved to 275 to about 300. Now, I think there was a survey of corneal surgeons who look at 350 as the baseline. But all the residual bed thickness was based on the concept that the cornea has uniform strength from anterior to posterior cornea, which we know with histology is not true. So this concept is also probably not the ideal one. I do stress on pre-op slit lamp examination because what I find, the minor lid abnormalities, the dry eyes, the cornea can cause chronic long-term inflammation. I have one patient of dry eye alone who progressed to keratoconus, and later we found it was a combination of dry eye and a mother having borderline keratoconus. So inflammation needs to be really looked at quite deeply. The concept of RSB has been there since we started LASIK surgery. So PRK, if you is a better option if you even have a doubt in terms of form fruus keratoconus. And the RSB concept works better, remember, for LASIK rather than for PRK. For post-smile, when they looked a review of literature, they found that across the three factors which we look at, residual bed thickness, the ectasia risk factor score, and the percentage of tissue ablated, there is actually nothing consistent. You can have a range in the safe to the unsafe zone. Now, there are some preoperative predictors which have been mentioned in literature, which I mentioned, the ERSS. The sensitivity is up to be around 92%. But what the understanding is that it tends to underestimate for keratoconus suspect and overestimates for younger patients. PTA is said to be a better concept, which has come in the last maybe about 10 to 12 years, which is PTA stands for percentage of tissue altered. And the predictability is about 97%, better than an RSB, and varies as per the procedure. Just remember that for LASIK, it is considered about 40% as the upper limit. Now, increasing the ablation depth increase the ectasia, and there are, of course, some mathematical models for it. In SMILE, the modified PTA is now about 20%. Now, I also looked at a review of how much of ectasia occurs after SMILE, and they looked at all the factors of the 7 eyes out of this almost 8,000 eyes who underwent SMILE, and as I said that the range of PTA varies in the safe to the excessive range, but I guess 40 is said to be the mean, and that's the reason. There is one large study from India from Sri Ganesh's group, and they also find that for the standard SMILE there is no predictive factor, but if you do SMILE extra for borderline topographies, none of the groups that had SMILE extra actually even in the borderline developed ectasia. So that's probably an important take-home point. So based on all the retrospective application of the criteria, it could be the ERSS, PTA or RSB, my understanding over now probably 20 years of refractive surgery is the very important point of BB. BB stands for Bhagwan Bharose. That means you really don't know when and how you're actually going to get it. Now, there are some, of course, additional risk factors, which is the pre-op topography, pre-op thinner corneas, flap thickness, gender, and biomechanical variable, which is a concept which has come in now in about 15 years. Of course, biomechanics of PRK LASIK versus SMILE are different. The tensile strength of SMILE is better than PRK and is better than LASIK. So that is an accepted concept. And every micron you ablate in the cornea, the tensile strength drops by about 0.2%. And if you increase the cap thickness, especially in patients with SMILE, it increases by about 0.08% for each micron that you increase. Now, corneal biomechanics was said to be the end all, but our present understanding is it probably adds some information but not a lot. Now, this is my broad paradigm for management of keratectasia in early and advanced. So if you have regular astigmatism, and this is a slightly busy slide, so I'll go over it slightly more slowly. So if you have early to moderate grade 1 keratoconus or keratectasia, if it's progressive and has regular astigmatism, you do a collagen cross-linking, give them good vision with glasses or contact lenses. You can use CXL in combination, and if there is a significant residual error, you can still put a toric ICL. The present understanding of intracorneal ring segments and cares is that it can be used for high myopic. It can make an irregular cornea a lot more regular, and then giving contact lenses or glasses makes it a lot more easier. If you have irregular astigmatism, you would still need to do cares or intracorneal ring segments, follow it up with a collagen cross-linking or in combination, usually about 3 to 6 weeks later, and that can give good results as well. In advanced ectasia, that is patients coming a lot more later, quite rare, more common in keratoconus, where you have poor best corrected vision, less than 612, you would need to definitely think about a DALC. And DALC results with the present approach with the IOCT are actually very, very good. 80% of them get best corrected more than 612. If there is no central scarring but a broad ectasia, you can do hypertonic associated collagen cross-link or HPMC, and you can do a toric ICL for the residual error. Intax SK, if it's can be used for steeper corneas or cares where you have 360-degree coverage, that can reduce the steepness of the cornea, and you can combine it with collagen cross-linking. In summary, the post-operative ectasia, though rare, has potentially devastating complications of corneorefractive surgery. The prevention is the best management, though screening is imperative. Consider lens-based refractive surgeries for those risk factors associated with post-operative ectasia. identify ectasia early, halt the progression with corneal collagen cross-linking. This probably would be the baseline before you attempt to do anything else. Visual rehabilitation could include glasses, contact lenses, RJPs. Scleral lenses, very, very good results even for early and advanced keratoconus. You can combine it with surgical in corneal procedures, and cornea transplant, at least for post-LASIK ectasia, is presently a last resort. Thank you so much, Swapna.
Thank you very much, Dr. Anand. I think we have come to the conclusion of both our time and our session. And
I have a retina surgeon who wants to ask me. I'm very keen to know what.
Anand, I just wondered if you have a borderline case. So what are the options available, whether you will go for a smile or you will go for an PRK, or what are the options you will give to the patient?
I would, depends on the two things basically. One is the thickness, second is the topography, third is the refractive error. So if these three you help, let me know, I can probably help you better.
No, if you think by ablation it will come to a border, somewhere on 410 or...
Ablation kitna hoga?
Ablation करके borderline पे आ रहे हैं हम.
What is the refractive power, if you remember?
No, if I come to a borderline somewhere on 410 or 250 bed strength.
This is with epithelium, without epithelium?
After the...
After ablation with epithelium, 400 is good enough. Yeah. 350 is now for low refractive errors. PRK is my preferred. Trans PRK works beautifully. Pain management is very good. Even for about 460, 470, we've done about 3 to 4 diopters. So that works quite well. Our cutoff for residual bed is 350 now. So that is uniform. Smile, if the powers are beyond -6, I would still consider smile. Implantable contact lens. Smile I would not consider for borderline cases because my contraindication for smile and LASIK is the same.
No, you said smile with the smile extra.
Smile extra is an option, yes. Or even PRK extra. Some people even do PRK extra. Just kind of give you the 10%. See, the extra part is how much is extra. Though extra sounds like some kind of medicine for...
so what is the plus minus range to go in to decide whether you will do an extra or you will not do?
Anything borderline, if you want to mentally just be safe, just go ahead. Because I think now the studies do show that even if it acts about 10-20% of corneal strength, and you may need to undercorrect the refractive error though, because it will flatten it by about 10%. So you won't need to undercorrect your refraction, but it will give you extra safety.
Thank you.
Actually, sir, this is covered in the initial part of this. We would have loved to have you here.